Hello, everyone. We welcome you all to this interesting session, which we have organized on behalf of International Children's Day. The session is titled Agree to Disagree. As the saying goes, for all the good ideas and for the innovations, we need interactions, we need conflicts, we need arguments, we need debates. So that's the highlight of today's session. It's basically about knowing the topic better by having different viewpoints being presented by two eminent speakers and two eminent strabismologists here. We welcome Dr. Akhila Ramkumar, who is a consultant at Nethralaya, Chennai. Dr. Akhila has graduated and did her post-graduation from RIO, Chennai. She finished her fellowship from Nethralaya, Chennai, works as a consultant there. We welcome you, Akhila.
Thank you, Dr.
We have our own faculty, Dr. Rajesh. We have Dr. Rajesh Prabhu, who works as a head of Department of Paediatric Ophthalmology and Strabismus at Sankara Eye Hospital, Coimbatore. He has done his post-graduation and fellowship from Aravind Eye Hospital, Coimbatore. We welcome you, Rajesh.
Thank you, Sowmya.
So I am Dr. Sowmya. I work as a consultant at Sankara Eye Hospital, Bangalore. I'm also a DNB faculty at the same institute. So let's have a brief introduction of the talk before we move on to the talks per se. The topic for today would be on moderate esotropias. As we know, there are many roads to orthotropia. So we would be discussing on two major surgeries, which are proposes two different schools of thought: bimedial recession versus a unilateral resect procedure to achieve orthotropia and moderate esotropia. I invite Dr. Akhila to present her viewpoint why she favors a bimedial recession in moderate esotropia. Over to you, Akhila.
Thank you, Dr. Sowmya. I would like to thank the organizing team for this opportunity. Now, my topic today would be to favor a bimedial recession over a resect for a child with a moderate esotropia. Now, is this choice simply the surgeon's personal preference? Well, the answer is still not a clear yes or a no. I would still say maybe, because you do not have any adequate evidence to support your claim. And that itself says that you need further research. And this was evident from the Cochrane Review of Intervention for Children with Infantile Esotropia. Now, when life gives you a choice, every choice comes with a consequence. And once you make a choice, then you must accept the responsibility and you cannot escape the responsibility, whether you like it or not. So with that, you have a child with infantile esotropia, moderate angle, child who has an equal vision, and there is no amblyopia, no particular fixation preference, and there is absolutely no anatomic defect in any one of the eye. I think most of us would agree that the possible or the preferred choice would be a bilateral medial rectus recession. Well, that would be my choice as well. Now, if you look at the choices that you have or the alternatives to a bimedial recession, the other surgical procedures, the most frequently preferred technique would be a by and large a bimedial recession. The reason being, this is a symmetrical procedure. So always symmetry allows angle correction without causing any incompetence on lateral versions. And this simultaneously corrects the bilateral imbalance, which is so characteristic of all these children with an infantile esotropia. And if you basically look into the pathophysiology of children with infantile ET, you always have these clinical phenomena, that is cross-fixation and abduction limitation, Okain asymmetry, which are all symmetric in, it is there in both the eyes, and it is always bilateral. So the obvious choice would be a bilateral surgical procedure. And you also know that there is an anatomical defect. There is a hypothesis that these children usually have an anteriorly inserted medial rectus muscle, which is also asymmetrical. Now, when you want to choose a technique and the outcome, if you compare a bimedial recession, if you look into the technique of a recession, I think all strabismologists would agree that a recession is always a more simpler procedure when compared to a resection, and it is always reversible, whereas a resection is a relatively more traumatic procedure. And in a bimedial recession, all these children, I think children who are operated for an infantile ET over a period of time might develop a consecutive XT, and you still have a virgin lateral rectus muscle, which is always there to bail you out later in life. And if you look at the outcome measures with regard to bimedial recession versus recess and resect, you have a few studies which still favor a bimedial recession, saying that it gives you better surgical success rate and relatively lesser reoperation rates with regard to a bimedial recession. So now what are the evidences that we have to support our claim? So now you have a few randomized control trials, which was done by Polling et al. And another clinical trial, which was done by Arnold. But these two studies, if you see, they do not clearly favor a bimedial recession. They say the outcome, that is a surgical outcome, is relatively comparable between the two procedures. But this study on comparison of the surgical outcomes between these two procedures by Yoonbi Kim, which was done in South Korea. Now, this study, which was done in almost 80 children, they compared the surgical outcome of all these children who were operated for either bimedial recession or a unilateral RNR, and they compared the outcome based on these criteria, that is the angle of mean deviation in the postoperative period, the surgical success rate, and the reoperation rates. Now, if you see, they had a clear, favor for bimedial recession. That is, the surgical success rate was relatively better in children who underwent a bimedial recession, and the reoperation rates were grossly lesser when compared to the RNR group. But when it comes to postoperative sensory status or the DVD, it was almost the same. There was nothing, which was favoring a bimedial recession. Now, there's another study by Von Uden et al. On binocular vision and ocular motility, where he says that he started off or initially favored an RNR on the non-dominant eye. This is even in non-dominant eyes, I'm telling you. But over a period of time, he changed his approach to a bimedial recession because he felt that there was an increased number of reoperation rates, which was required to either maintain or to gain alignment in the future. Now, these are some of the other studies which I had gone through, which kind of favors a bimedial recession. That is a study by Castro, which was done on almost 127 children. But this was not necessarily that this surgery favored a better surgical outcome. It was for various other reasons, the ease of surgery and so on. So these 4 studies which I had seen have favored a bimedial recession over an RNR. So when it comes to children who have equal vision, good vision in both the eyes, there is no underlying amblyopia, and who do not have any fixation preference, and in the absence of any anatomical defect, I would still prefer a bimedial recession over an unilateral recess and resect. Thank you for the opportunity.
Excellently summed up, Dr. Akhila, including the evidence-based approach. So we would hear the other standpoint now. I invite Dr. Rajesh to present his technique, that is unilateral resist resect and esotropias. Over to you, Rajesh.
Yeah, thank you, Dr. Sowmya and Dr. Akhila. So this is my preferred practice in a case of a moderate esotropia. I use limbal incision for all the cases. So after limbal incision, I do a thorough muscle dissection and use 2 single-arm 6/4 Vicryl sutures on both the ends and secure the muscle tightly. My maximum numbers for recession in MR medial rectus is 5 mm. I don't do anything beyond this. And my maximum number for LR, whether it is recession or recession, would be 8 mm. So after securing it tightly to the sclera, I close the limbal section either with the 8/2 Vicryl, or recently I have started using fibrin glue for the closure of the conjunctiva in most of my cases. This is a small video showing how resection is being performed. Okay, now the main important discussion is like why I choose R&R over bimedial recession. Is not just the fact that I have learned R&R from my parent institute. I've been taught to do R&R. That is not the only reason. Over the past 14 years of my practice, I have analyzed many factors like what is the ease of doing the surgery, how confidence is from the parent's side, what is the predictability of the procedure of choice, and which is the procedure of least and minimal complications, and what about managing further surgeries if the same patient presents to us with a residual squint or maybe a consecutive squint, which is the better procedure to do. And of course, long-term stability, both in terms of sensory as well as motor fusion and the outcomes. So after analyzing all these factors, I'm still practicing R&R. for the following reasons, which I will try to substantiate. So this is what my personal experience is like. Counseling the parents, I feel very easy with R&R procedure than bimiral recession. And I think both of you will agree with me that many patients come with the intention that the squinting is only present in one eye, or sometimes they tell that the squinting is present in both eyes, but more in one eye. So sometimes I feel very difficult to convince them for both eye surgery. So I just go with the patient's complaint that whichever eye they feel squinting is more or squinting is present, I do operate that eye first. And then I clearly tell them that the other eye surgery might be needed if there is a residual squint later. So this is one important factor which I have learned through the last few years, which made me to choose more of R&R procedure. And as Akhila has also mentioned that the vision should be equal in both eyes for a bimiral recession. So if the child has got any amblyopic, whether the vision could be recorded or any preference, then where you suspect some amblyopia, always R&R is the preferred procedure of choice. And as I went through literature, there was no statistically significant difference was found between a bimiral recession or an R&R as surgery for infantile esotropia. This was a study which was done in April 2009, published in British Journal of Ophthalmology. And other study, which is found in Arch Ophthalmology in February 1985, this is a very important point. The postoperative ocular alignment was better, and the need for subsequent strabismus surgery was less in patients who initially underwent recession resection. So the authors were favoring more of an R&R procedure. So these are few of my patients where I follow the same procedure, even whether it is whether they are infants or adult patients. The results are very good in my hands. So these are other few photographs where you can see a simple R&R in one eye gives a very good alignment. And these patients are being followed up regularly for the past few years, and results are maintained in the same way. So again, this is more important, which I consider that whenever we need to correct a residual squint, as in this case, you have a large esotropia, and then after the R&R procedure, we have a residual esotropia. I always feel doing a bilateral resections will not be much predictable than doing an R&R. So, and I think most of us will accept that recession and resection work well together when it is combined, rather than doing a recession works well if it is done alone, but resections generally doesn't give a very predictable results when it is done alone. That is one reason where I always prefer to do an R&R in one eye and then followed by R&R of the other eye whenever there is a residual squint. This is most important factor which I come across. Even the literature also supports that. In one of the journal in February 1985, they showed higher incidence and greater amounts of exodeviation after bimiral recession. Even in my experience over the past 10 years, I have seen a lot of patients presenting to me with consecutive exotropia, or those children who has been operated bimiral recession in the infancy or in younger age group. This is my experience. And this one experience I'll just share with you. There's a good collection of photographs by the patient himself. He is presented with a large squint around 1 year and 8 months, for which a bimiral recession was done. And I was aligned for a few years, and then slowly it started drifting over the period of 10-15 years. And then he presented to us with this a large exotropia. Finally, we will have to do a re-advancement of the medial rectus to the original position, and we did one lateral rectus session, and then I was aligned. So this is what, in my experience, I have experienced so many patients coming to with the consecutive exotropia, or the one which have been operated for a bimiral recession. So to conclude, counseling is better if we plan one eye followed by the other eye later. And amblyopic eyes, it is well established that R&R is the best suited procedure. And recession, resection complement each other and works good if it is combined. And many studies are there showing there are some palpable facial changes after an R&R procedure. To my personal experience, I have not seen many, at least in long term. Initially, few weeks, there are some changes, but over the period of long term, there are not much of palpable facial changes associated with the R&R procedures. And long-term stability of the angle is good in my hands. So these are few other patients who has been aligned perfectly with the help of R&R procedures. So thank you for the opportunity.
So that's exactly why I couldn't thank Rajesh. Excellently presented talk, Rajesh, and
thank you so
well
much.
Presented with the cases. It's not like a judgment, as we all of the viewers would have understood by now. So what we actually look at any particular, choosing one particular procedure over the other would be that the particular condition in question comes into play, as what Dr. Akhila and Dr. Rajesh both were mentioning. There are a few things that we take into consideration. That probably the first thing would be either it is an accomitant squint or an incomitant squint. If it's a accomitant squint, probably we would way towards doing a accomitant procedures like a bimedial recession. If it's an incomitant squint, probably we would tilt towards doing a unilateral resect procedure, as we know for the obvious reasons. There's also a study by Dima, which I thought would be interesting to mention, because he looked at lateral gaze incomitants when we did a resect procedure. What he saw was lateral gaze incompetence was more often when we did an asymmetrical surgery versus doing a symmetrical surgery. So favoring a bimedial recession versus a unilateral resect in case of a incompetence squint. Again, probably food for thought would also be, apart from the ocular movement limitation, when we have a long-standing squint, when we have a larger squints, the FTD becomes really very tight. So in both the eyes, limiting the movement, though ductions are completely full, when we check the versions, it's limited. So the patient gains a little amount of increase in the visual fields when we do a bimedial procedure versus doing a unilateral resect procedure, though under corrections would be a little more common when we did a bimedial procedures in a long-standing squint. So there is both a to and fro in the same condition. Apart from that, both the speakers, both of you told about the same thing in terms of visual acuity being lesser when it is a larger squint, when there's an amblyopic eye. We know the obvious choice is going to be a unilateral resect procedure, and we would not think in terms of a bimedial procedure. The other interesting thing would be in cases of a restrictive squints causing a esotropia. In those conditions, I think recession would always be a choice versus doing a resect procedure. Say in case of a thyroid eye disease or a DRS, when we would probably think in terms of doing a bimedial procedure. Doing an adjustable on a bimedial becomes a little more easier compared to doing a resect and then adjusting it, considering the amount which is required in a resect procedure would be a little larger. Lastly, probably when we look at the cons of the procedure, we forget that when we do a bimedial procedure, convergence anomalies or convergence insufficiency with time would probably come into forefront, unlike in a unilateral resect procedure, or a palpebral fissure changes or lateral gaze incompetence as a cons in case of a unilateral resect procedure. So both the procedures have a say in particular kinds of squints. Again, it boils down to what are we dealing with in question. As what Dr. Rajesh and Dr. Akhila were discussing about a consecutive XT following everything, I think consecutive XT is a norm in case of a ET, provided we follow them up that long, either of the procedures that we do. In that scenario, either of the procedures could be taken into. Bimedial recession always gives us an opportunity to reverse the procedure completely and look at it as one of the options to correct a consecutive XT. Unlike in case of a unilateral resect, probably you have already resected one of the muscle, LR, and MR is already resist, and that leading on to consecutive XT, you would be probably advancing the MR as a secondary procedure. If we consider doing that, then probably we're creating a nitrogenic DRS. Those are my thoughts on choosing either of the procedure. As said, there are many routes to orthotropia. Whichever you choose, largely it depends on 1, the evidence, 2, what works best in your hands, 3, and most importantly, the condition in question. Are we catering to the condition in question in toto, not just looking at primary gaze orthotropia, but looking at more beyond just orthotropia. I think both of you would kind of be happy that I didn't favor either of you. So,
yeah, that's true, Sowmya. That's very well summarized, actually. There are factors which favors one procedure over the other, and there are cons which we have to look into. And again, as you mentioned, that which is best in your hands over a period of time, and your follow-up, how the patients are being followed up over the years, how the results are in your hands is the most important factor finally. finally, which is going to help you.
Thank you, Dr. Akhila. Thank you, Dr. Rajesh, for having this wonderful discussion on esotropia. I think all of us have learned from each other as much and enjoyed the whole session. Thank you very much.
Thank you, Sowmya.
Thank you, Sowmya. Yeah. Thanks, Akhila.
Yeah, bye, Rajesh.